Welcome, everyone. My name is Michelle Niehaus. I am the Program Administrator for Deaf and Hard of Hearing Services with the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. And we are so excited to have you all here today. We're going to be talking about how to engage in respectful dialogue about communication access with people who have hearing loss. And I am still letting people in, so I'm trying to play a couple different roles here today. Today, what we want to do is really open dialogue about how behavioral health providers and associated folks can make sure that the communication access is in place that people need so that we are grounding the work we do in respect and good communication. And so we have several panelists with you here today. We are also recording today's session. So if you learn something great and you want to share it, we will send you that link and you can share the link with your colleagues. This is the first of 4 workshops that we're offering to help our community mental health centers and community partners think about meeting the individualized communication needs of people with hearing loss. Today, we're going to develop a foundational understanding of the lived experiences of people trying to engage in treatment or recovery services with a hearing loss. Beyond the fact that there are laws requiring effective communication, the why we do this will be evident to you as you hear different stories today. We also know that it can sometimes be uncomfortable to ask about these things. We plan to give you some examples of how to engage in respectful dialogue and what to ask to get the information you need to provide effective communication. You should have access to a Q&A box. Please use that. Or if I miss your chat, feel free to pop it in again. I'm going to be trying to take notes and keep us on track. But the folks on our panel today have so much to share. There's no way we're going to cover it all in the time that we have. So I am super excited to have you all here today. And I want to first thank our communication access providers. For ASL interpreting, we have Linda Bozeman and Shannon Greider. And for our professional captioning, we have Laura Kogut. You may notice if you turn your captioning on, it looks different. We are using professional captioning today. It is much higher quality, and it does meet Americans with Disabilities Act standards in a way that auto captioning does not. So you might use that as an opportunity to compare the difference today. So let's go ahead and meet our panelists. And I'm going to go in the order that folks are on my screen. When it is your turn, please tell me your name, how you prefer to communicate, and what perspective or perspectives you bring to today's conversation. Why is this training for behavioral health providers important to you? And sorry, Emily, you were first to join, so you get to go first.
Hi, my name is Emily Kimbell, and I trying to switch mode and not talk like I'm in the office all day. So obviously I speak for myself, but I do have hearing aids, and so I do rely on captioning and interpreters in some situations. But anyway, the point of being here today is my goal is to help you all to see that there's not a one size fit all. And I think it will be very apparent in our panel today once we all start to sharing our stories. So I want also to think about your field as in a mental health provider. One of the biggest things that we do is communicate, and obviously effective communication is the way to get a proper treatment. So I'm very excited to be here, and I'm looking forward to continuing this conversation.
Thanks, Emily. You also play a really important role as an information specialist at the Kentucky Commission on the Deaf and Hard of Hearing. So you're bringing into the room not only your experiences, but also the
Just got
experiences of
switched
folks who call
to
you for
1 to
support.
6 on.
And Shannon, I think you need to mute yourself. Thank you. All right, we'll need her voicing skills in a few minutes, but right now it sounds like she's taking care of something else. All right, Tessa.
Hey, can you hear me? Okay, to make sure. Okay. Hi, I am Teresa Fain. I'm hard of hearing. I wear hearing aids. My struggles in medical settings have been challenging. I've had three surgery, and all three were difficult when prepping beforehand. I constantly had to remind the staff to lower their masks so I could see their lips. As people has often forget that I'm not hearing. I was able to keep my hearing aids on right up until surgery, but it was still difficult. Here's another short story. When I visit a doctor, they look into my ears. When they look into my ears, they often think, they don't think to wait until I put my hearing aids back in before they start speaking. And this happens all the time, every single time I go to the doctor. I prefer to communicate without interpreters because I feel that sometimes interpreters do not translate my words very well or miss important parts when I use ASL. Um, in the mental health setting, I attended support groups and sometimes use ASL, and almost every time the interpreter misses something I said or doesn't convey what I mean, which is really frustrating because I have to keep correcting them. I understand that we're all human, but this happens far too often, and I'm looking forward to spread awareness about these issues.
Thank you, Tessa. And you also play a role for us as a peer support specialist. Can you say a little bit about that, please?
Yes, I'm a peer support specialist for the deaf and hard of hearing community. We are not counselors or anything. We just support them when they need resources or just help them in their mental recovery.
Thank you, Tessa. And that's not just, don't minimize the important role peers have.
Well, sure.
Right. Jeannie.
Hi, my name is Jeannie Taylor, and I do have a severe to profound hearing loss. I relied on hearing aids, and I do communicate by listening and spoken language. I do know American Sign Language at a conversational level. I'm not highly skilled by any means. Um, it's very difficult for me to hear a conversational level speech. It's nearly inaudible if I don't have my hearing aids on. And it's really important for me to make sure that providers understand that. Also, in my own experience, I find my stress levels seem to rise in certain situations, especially in medical situations. And I think it's because you're in a position where you're about to receive a lot of perhaps complex or technical information. And a person with hearing loss has to spend a lot of effort just listening so that, and it's very tiring. And so when you're trying to receive information like a diagnosis or information about how to take a medication or just even scheduling your next appointment, sometimes I've struggled to the point that I'm spending so much time trying to listen that I miss those important details. So as a person with hearing loss who depends on spoken language and listening and hearing aids and all those other things, it's really, really important to me that I have a lot of visual cues that I'm able to see the person's face because I depend a lot on facial expressions. I can lip read some, but that is, if you've read any research about lip reading, only about 35 or 45% of what you think you're seeing on a person's mouth is accurate. So I think this again that this meeting, this training is really, really important for you all to understand that that there can be a lot of miscommunication. And when that happens, there's a lot of distrust that starts forming. But anyway, I'm glad to be here. And if I can help you all in any way, I appreciate that. I appreciate the opportunity to do that. Thank you.
Thank you, Jeannie. And you also bring with you the perspective of being a longtime member of our advisory committee.
Okay.
We have an advisory committee on the need for services for people who are deaf or hard of hearing, and Jeannie chaired that for a very long time. And the tool that we're going to be talking about today, the Communication Access Plan, was actually brought to us through Jeannie and her connections. So I just wanted to thank you for that and helping us improve our ability at the department to look at all the different ways a person may communicate. It's not only is it not one size fits all, but it may be multiple ways for one person to communicate in a given situation. So thank you for helping us to get better at figuring out how to document that and meet those needs.
You're welcome.
Judith.
Hi, my name is Judith Gaddie. I'm an adult and also a family peer support specialist at 7 County Services. I work mostly in Jefferson County, so Louisville. I prefer listening, spoken word. Sometimes I use captions and I can read lips, just a very small amount. I am a late deafened person, although I did have surgery as a teenager that repaired my hearing to within 2%. So I lived most of my life as if I was a hearing person. And it wasn't until the last less than 10 years that I've actually had to wear hearing aids. And at first was one ear and now it's both. And I have a moderate hearing loss right now. I had, I'm a peer support, so I can talk about my lived mental health experience. And as a peer, the reason why we shared that is to encourage other people to open up and to understand that they're not alone and that there is hope for recovery. So I had a major depressive episode because of the intersectionality of hearing loss and grief and being an African American woman at a very dangerous time in this country for African American women. Breonna Taylor's killing and all that had a profound impact on me. And I found myself having a significant amount of difficulty in society because of trauma. And I was able to get some help, and someone suggested that I become a peer support specialist. And that's helped me quite a bit to interact in the deaf community, which I never was a part of. I didn't know, and I almost never been in any kind of situation with ASL interpreters, Spanish language, yes, because I'm a longtime public administrator. I lived in Mexico from 2014 to 2016 as part of the Peace Corps. I've worked in universities, but this is all a whole different ball of wax. And I really hope by participating in today's workshop that I can help others to maybe not have to go through what I went through. And I think I may have covered everything. But if I didn't, please let me know, Michelle. Thank you for giving me the opportunity to share my story.
This is Michelle. Thank you so much for your willingness to share your story and to talk about the complexities. No one person is a single story. And I really appreciate your openness to talking about how mental health challenges intersect with hearing loss, intersect with race, intersect with what's happening in the world. There's so many different things that affect how we communicate and how we engage with one another. And your openness to talking about that with us and with those you serve as a peer is a gift. So thank you for that. Last but not least, we have Anthony.
Hello, everyone. My name is Anthony Adkins. I am fully deaf, and I do use American Sign Language as my main mode of communication. I depend a lot on interpreters, especially if it's job related, school related, or any sort of like doctor appointments. I'm always asking for an interpreter for my access. And it's important for me to share my story with you all so that you understand why, we've had all these experiences all of our lives. And then if you even think about the previous generations, they had these experiences. And so we're just trying to make things better, not only for ourselves, but for the future generations that come along.
And Anthony, you wear multiple hats. You serve as a program coordinator with our department, and you've brought a vital perspective as a deaf professional into our department. And you also serve as a deaf adult peer support specialist and have acted as a bridge between our department and the peers across the state. So you bring so much knowledge to this conversation, and I thank you so much for your willingness to talk about that. There's a lot that we can talk about together. I invite you to put questions in the Q&A box, just in case I miss it in the chat. And you might hear about positive experiences as well as negative experiences today, but it's all so that we can think about lived and living experience and how it influences how we go about our work together. Communication access is the responsibility of everyone on a treatment team or working at an agency providing services. We know that there are people in the training from many different kinds of programs. And so as we dialogue today, like Emily invited you, I also invite you to think about what the experience of a sign language user or a person with hearing loss might be in your program area. Person-centered communication access planning can help build not only access, but also trust, like Jeannie emphasized. And one strategy that we are promoting is the use of communication access plans in individuals' medical records. I'm going to share a screen in a minute and briefly show a sample version. For those of you who do not like the acronym CAP, it's not a corrective action plan. It's a different thing. It's a communication access plan. Our goal is to take this into a proactive place so that people can have dialogues between their providers and the folks that they're serving to avoid communication breakdowns. Okay, I'm going to go ahead and share my screen. And I'm going to check in. Anthony, are you good? Can you see?
One moment, let me scroll down. Okay, yes, I can access the interpreter.
Okay, excellent. All right, so what you are seeing now is a sample template for a communication access plan. And this is part of the Kentucky Overdose Response Effort, or CORE toolkit that we're creating for providers. Our goal with the whole toolkit is to make sure that our providers have a better understanding of how to develop communication access. And it all comes down to that service that we're providing with the person who is trusting us to support them. There is no one size fits all when it comes to communication. And so this is a guide to explore what will work best in a particular setting. So as you think about your own programs, there may be questions that you would add or subtract. This is just a template as a beginning point, and our department is happy to work with you to adapt a version that would work for your program. We want effective communication to be provided at all points of service, and we do encourage you to put this in the medical record or client record so that staff have easy access if there's turnover or if something else happens. And it can be revisited annually or more often if things change. So we just start off with the basics: name, date of birth, medical record number. We ask about what describes you: deaf, hard of hearing, or deaf blind. And we're going to go through this in section by section with our panelists, but I want to just give you an overview of the document first. We also are asking about what devices a person may use: hearing aids or cochlear implants. And there's space in there to write if you use something else. What do you need the facility or office to provide? And what services do you prefer? We also ask about environmental adaptations and waiting room practices. Then we ask about scheduling or follow-up communication, and provide a little bit of space for other things a treatment or recovery team needs to know about communication access. I'm going to stop the share. Make sure we're good with communication. Okay. One easy adaptation that we can all think about, and I still have to remind myself all the time, is to slow down the process a little bit. To talk a little slower, to make sure that you're not over exaggerating, but also if you're sharing a screen and working in a virtual environment, that you don't keep changing screens in a way that would make it hard for people to see an interpreter or make sure their captioning is still functioning. All right, so before we go section by section through the CAP, I'm curious. For our panelists, have your therapists, case managers, or other behavioral health providers ever asked you these kinds of questions before? If so, how did it help? And if not, how did it affect your treatment? And I'm going to invite Tessa, Judith, and Anthony to answer first if you're willing.
Sorry.
Okay, no, you're good, Tessa.
I had to turn my heater off because I'm cold. What was the first question?
Have you ever had a behavioral health provider ask you those kinds of questions before?
No.
If they had, how may it have helped your treatment experience?
When I was I went to the hospital when I was 13, and that was before I even knew sign language. So I couldn't really depend on an interpreter. So I just really, I mean, that was really hard for me because I had to depend on just hearing everything, by myself. And um, yeah, that was really hard. So what was the second question?
If they had asked you, how may that have helped you to have a better experience?
If they were more patient with me and enunciation would have been really good, to look at me when they're speaking, that would have been really helpful. In group settings, that was very hard because I didn't know sign language and there would be too many people around the circle. Just speaking, I couldn't hear everything. So,
Judith or Anthony, would you like to answer the question? Judith?
This is Judith. Yes, I'd like to answer. Thank you. Can kind of echo what Tessa said. When I had surgery many years ago for my significant hearing loss at that time, there was no such thing as having ASL or any. They didn't address my hearing loss, even though I was having surgery for hearing loss. And that was hard. I'm sure it traumatized me as a teen. In fact, I think it caused me to not ever want to even acknowledge that I couldn't hear or that I had hearing loss. So I missed out on a lot over the years because I never wanted, whenever I started having problems in school settings or anything, but I'll brings back around to health setting. I just didn't get the help that I needed. Now, more recently, during when I received services at 7 counties, um, they have started a communication access plan like in the last year or so, but I actually had to prompt my provider to actually put one in place. She denied its existence at first, and I work in the department that helped make this a reality for all the other people receiving services from 7 counties. So I knew about it. And she said, but you're here, but you're fine. Yeah, I don't need to do anything different for you. And that's not true. She just assumed because you can't see that I have a difference, that I understood everything. Like some others have said, I really do need to be facing you. And even in Zoom, I don't particularly care for captions necessarily because I'm looking at the captions instead of the person and I'm missing cues. And it's draining and it's exhausting. I think Jeannie said that as well. So yes, I have been here at 7 counties since they have instituted this across the board. And I have made sure any clients that I have who have hearing loss, that there's a cap in place for them. And people have been more willing to do that as time has gone on, partially because we also had training here for the entire staff that was mandatory.
Thank you, Judith. Yes, that ongoing advocacy is so important. And there's a lot of our programs experience a lot of turnover. So I think another piece that's exhausting is that even if we do education, it doesn't mean we don't have to do it again next year or the year after that or the year after that, because we always have to make sure people are up to date on the best practices. So I'm hoping that we can do a cultural change where the communication access plan becomes standard and it's just, oh, we just do this, not as an exception. Anthony, would you like to add anything?
Yes, Michelle. You know, depending on whether it's therapy or doctor appointments and the like, typically they'll say, well, how can I get an interpreter? You know, that's a repeated question that I often have to address. So I have to educate them on what the process is. So I have to self-advocate. Not only that, but when I educate them and then we've got everything set for the next appointment, maybe 2 or 3 weeks later, and it's time for the appointment, I go ahead and call 2 or 3 days ahead of time and say, have you arranged for the interpreter? It's like, oh, we forgot to do that sometimes. Oh, we forgot to do that. And sometimes they have everything in place. So that's the type of thing that, you know, they're just clueless about. You know, they've not gotten formal training and whatever education I've given them, that, you know, they're still learning and I'm still educating. So the tolerance level, you know, we're patient with each other. We have to interact. We have to see that those services improve over time. So yeah.
Thank you. So that's an added burden that not only do people not ask, but if you tell them what you need, they still want you to give them the how to do it. And then you have to explain what to put in place. So you have an added burden during a time of crisis or during a time when you're in need of medical care. And that just adds the opportunity for miscommunication, for maybe not showing back up for an appointment. Sometimes we talk about like failure to keep appointments or no-shows. I think that communication barriers can prevent people from wanting to go back. Barclay, I see your question in the chat. I'm going to ask you to put that in the Q&A panel so I don't lose it. That's a later question around language deprivation and accommodations for people with language disfluency. We're starting with the basics right now, and we're going through section by section of the communication access plan. The first section asks, which describes you? And then it offers 4 options: deaf, hard of hearing, deafblind, and blank. For our panelists, what do you think of those options? Which would you choose and why? And I'm going to encourage Emily and Jeannie. Oh, go, Emily, you're ready.
So, what do I think about these options? So I'm just going to be honest. Statistics show that it takes 7 to 9 years for a person that will admit they have a hearing loss. So you may suspect that they have a hearing loss, but they may not identify themselves as hard of hearing. So they may just say, I don't have a hearing loss, or I have a hearing loss. So it's more an identity preference. It's not so much of it's not looked at as a medical per se. So, some people will be just straight out. If it was me filling out, I'll just check hard of hearing because that's what it is. And I've been hard of hearing my whole life, and that's what I've used. So, for me, it wouldn't be an issue. But for some, it could be a lot of just denial, and they won't even admit to it. So, that's just something to also to think about.
That's an amazing point. I think that we like to have check boxes, right? We like to say, this is where you fit. And that's not necessarily where a person is, and how a person medically presents and how they present by identity may be very different. And sometimes I'll hear from providers, we know so-and-so has a hearing loss, but they don't want to get help, which is a whole other level of barrier, right? If you're trying to offer an accommodation and they don't want it. So those are other things that providers may need to think about navigating. Jeannie?
Yes. I would identify as hard of hearing. And as far as what I think about the options, I think those 4 options are good. I think if we even added another statement on there that says, I have hearing loss, that they could check, because some people don't understand those identities, as Emily just spoke about. So that might be, they may say, I'm not that, or that, but they may check off, I have hearing loss. So again, just kind of repeating what several of you have already said, hearing loss exists on a spectrum. So you may be on this end of the spectrum where your hearing loss has very few noticeable changes, all the way to this end where you're profoundly deaf, you hear no sounds at all. So, but does the public understand that? I'm not sure. I think you have to start somewhere, and I think that those identities are good. As far as anything else, I can't think of anything else right now that I would add to that. But I think they're okay.
I appreciate you adding the idea of a section that just says, I have hearing loss, check. And I'm also really surprised you didn't bring anything up about deafblind, because usually that's your area of making sure that folks who are deafblind are considered. Can you give us just a minute, because we don't have representation on this panel, talking about what a person who is deafblind may look like, or what that may be?
Okay, so a person who is deafblind may look just like me. I mean, I have on hearing aids, I wear glasses, so I have reduced limited vision. So when you see that word deafblind, a lot of people think of Helen Keller. I mean, most of us have learned about Helen Keller in our schools. We've seen movies about her and things like that. But you have to think outside of that. A person who is deafblind could have hearing loss and low vision. So they may identify as deafblind. I don't identify as deafblind because my vision, I do have vision loss, but it's not to the point of it's not to the degree of near blindness or anything like that. So So yeah, there's a lot of people who identify that way, and they need lots of accommodations. Lots.
Thank you, Jeannie. Anthony, I'm going to put you on the spot as our only signing panelist today. Can you talk a little bit about what deaf identity may mean or deaf culture? If somebody checks that deaf box, what might that mean for someone?
Yeah. Making that check for myself, identifying as a deaf individual, it means that, they could run the gamut on what that deafness is, but you have to ask, what is your preferred type of communication? A deaf individual can sign, but they might be able to speak for themselves. They may be able to hear some and then would prefer to take notes. So even having that check deaf, my communication needs can vary. I prefer full signs. Now, I used to speak for myself, but I've turned that off because I got mocked a lot as a young deaf person with a voice that, didn't quite fit. So I got to the point where it's like, okay, I just thought it was easier just to say I'm deaf voice off, and sign everything. So that's what worked for me.
Thank you. Tessa or Judith, do you want to add anything about the identity questions? No? All right. Well, before we jump into the section about devices, we are actually going to take a brief break. Well, one thing to think about when planning for services is the fatigue that can happen. Judith mentioned it, Jeannie mentioned it, from having to pay so much attention to speech reading or interpreters or captioning or some combination of that, it can be very, very exhausting. So when you have a longer meeting, like ours is an hour and a half today, it's good to take a break. It also gives our communication access providers a little bit of a break as well. So it is 2:42 on my clock. We're going to come back. Oh, now it's 2:43. We're going to come back at 2:48 after just a very brief break. And Anthony's going to pause the recording.
Will do.
Good job. We even remembered to start recording again. All right. Welcome back to the second part of our conversation on engaging in respectful dialogue about communication access. Some of you may have been a little uncomfortable with taking a break halfway through. That was my timer. About taking a break halfway through or slowing down communication. I think one thing that we have to think about in our respectful interactions is to do self-analysis on what we may unintentionally do that makes things harder for the folks we serve. That multitasking to get notes done or rushing from one thing to another, that can create a lot of barriers for folks in and of itself. Judith, are you good? You're very focused. You good? Oh, okay. So we're going to move into the next section. Oh, she's struggling. While she figures out her access as well, I think she's having trouble with her audio on her computer. We're going to ask in the next section, what device or devices do you use? And that focuses on hearing aids and cochlear implants. Why do you think it's important for a behavioral health provider to know if a person uses a hearing aid or cochlear implant? What do you think hearing people need to know about the realities of using hearing aids or cochlear implants? And I'm going to invite Jeannie, Emily, and Judith to start with that one. Jeannie?
I'll be brave. I wear hearing aids, as I've already told you all. And I think that the reason why it's important for a behavioral health provider to know that ahead of time is to make sure that you collect the information you need from me to know what accommodations I may need or communication devices that I may need in order to make the most out of my time with you. I think that, again, like I said a few minutes ago, that listening takes a lot of effort. And if I'm wearing hearing aids and we've already had a discussion about that and you know that, then that will make for a better time together. Also, I think it's important that providers understand that hearing aids do not cure hearing loss. They don't restore the natural functioning of the ear. They do just what they say they do. They aid in hearing, and that's all they do. And even with hearing aids, it is sometimes hard for me to hear speech in various settings. So I think, again, what's important about the communication access plan is just collecting that information. It makes you proactive. It gets us off on a better foot as far as what we're going to be doing in our time together.
Can you say a little bit more about how your hearing might be different in different settings? Or how
Sure.
your hearing aids may be more effective or less effective, depending on where you are?
Right. So, one thing that impacts my listening, being able to listen and be able to hear, is the listening environment that I'm in. So if I am in a large room with lots of hard surfaces and there's a lot of echoing in the room, or there's high ceilings, all of those things impact the speech that I'm trying to understand from the speaker. Another thing that impacts my ability to hear well is the distance that I am from the speaker. So the closer I can get to you, the better. If we're far apart from one another, that's going to increase the challenges for me to be able to hear what you're saying. I don't know, things like that. How's that, Michelle?
Excellent.
Okay.
Emily was ready to jump in. Go for
Okay.
it, Emily.
I was planning to say most of what Jeannie has said. So I wear hearing aids in both ears. But one thing that you have to keep in mind is obviously Jeannie and I have a hearing loss. We both wear hearing aids, but our needs are totally different. If it's one-on-one, I'm good. If it's in a group setting, it depends. It depends. If it's just four of us, I do pretty well. If there's a big group, like a Sunday school class, that gets really challenging because we're more spread out. So don't just assume that if a person has a hearing aid, they're all good, because it just amplified what hearing you have left. So you just really have to talk with the individual and get what their communication needs are. Um, it's not a one size fit all. Period. It's not.
We have some people on the call who work in residential settings and may work with people who use hearing aids and have cognitive issues, may have developmental or intellectual disabilities. Can you say a little bit about what a person needs to know or what staff may need to know about maintenance and cleaning of hearing aids? Because I don't think we always consider that.
Didn't really think about that, Michelle. So it all really depends on what type of hearing aids. I won't go into all the technical stuff, but if they're rechargeable, they just need to make sure that they are accessible, and then that they're charged up every night. That can get a little tricky on, I don't know what like the schedule, if there's bedtime um, at 9 o'clock and they take their hearing aids out, that's it, So it's kind of hard to just kind of give a blanket statement on that. But when it comes to cleaning, it's really important to communicate with maybe the guardian or the audiologist to how to clean it, because they're all different. So that would be the first step to do. It's pretty simple. It doesn't require a training or anything. It's just be mindful of the needs are, and sometime if they're not hearing you well or not responding, it could be that the battery's dead. So so if you're needing to confirm if their hearing aid is working, sometimes you can squeeze it and it'll make a noise, or you can just simply put it back on the charger if it's green or red. Red means you need to charge it up. But I lost my train of thought. Hold on, let me think.
Well, while you're
It left me.
That's okay. I was having images of the state fair because one of the things the Kentucky Commission on the Deaf and Hard of Hearing does is host a booth most years, and we give out free hearing aid batteries. And that would be like the most popular thing. And people would come and grab like tons of them. And those suckers are tiny. So we've had lots of conversations about having to replace the hearing aids, sometimes older adult or hearing aid batteries. Sometimes older adults would really struggle with that. So knowing how to replace the hearing aid battery is another piece. Jeannie, did you have something to add?
Did just Emily, I think whatever you were losing, it was you were sending to me to say. It might be important for the providers to know, especially in that residential setting that you were talking about, is that the life of a hearing aid is only about 7 or 8 years long. So 7 or 8 years is about the life of a hearing aid. So, it's important to continue to check it and keep it properly functioning. I don't know whose responsibility that is in a residential setting, but those are some things to consider. Also, if the person does not have rechargeable hearing aids and they are still using batteries, there are battery testers out there that most sometimes are even free, that you can do. And those things are skills that could probably be easily taught to a resident. I can remember Michelle and I worked with a resident in the southwestern part of the state many, many, many years ago. And the providers did not know these things, and when they knew them, when they were informed, it was like a light went off, and they were so eager to help and so thankful for the information. And it honestly made a huge difference in the life of that lady who was receiving care in that residential setting. They taught her to use the battery tester to test her own batteries. I don't know. I will never forget that time that we had with that particular resident. It was great.
Emily?
Came back.
Oh, say more.
It came back. I was like, oh, there it is. So I was just thinking about being in a residential setting, and so you're working with your patients, and you need to make sure that they're understanding what you're asking them to do or answer your questions, or you're trying to figure out, are they hearing you? One thing that people don't realize, at the norm, we're also used to saying, "Can you hear me?" Well, yeah, I can hear you, but that doesn't mean nothing. When you ask the question, "Do you understand me?" Then you're asking, "Do you understand what I just told you?" And then you can kind of do the talk back method. So don't just assume if they heard you, because we can hear anything what hearing we have left, but that doesn't mean nothing. So that's always a good key to use when you're communicating with your patients, is ask if they're understanding and not, are you hearing me?
Oh. This
Judith?
is Judith. Okay. I can echo everything they've said. I just wanted to add a couple of small things for a residential setting that might be helpful. If people are using a CPAP machine for breathing and it has to be cleaned daily with like a baby wipe. I've found that that same baby wipe is really good for cleaning my hearing aids. It's not very, it's not too harsh, and it's unscented. And it takes off a little bit of the earwax if we're going to get to the nitty gritty, because they do collect that. We also we've been trained, most of us who have hearing aids later in life. I know I was trained to take off one small little piece on the I don't even know what it's called. See, but it's at the tip of the little speaker that's in my ear. And there's a device that I can use to get that off and put on another one and throw it away. Those, you might want to have extras. Yes. Does someone know what that is? Or no? Okay. I thought I heard someone going to jump in. So have extras.
Sorry, Tessa, did you have your hand? No, okay.
We're good.
Oh, okay. Extras of those. Most of the more up-to-date hearing aids do have Bluetooth technology, and they are on a rechargeable device. I didn't know about the colors. I was putting it in there, and I didn't know that if it wasn't green, it was not charged. And it has something to, it also helps that there are portable ones that can be used, like if someone's traveling or something like that. I think I've covered everything I wanted to add that others may have. Oh, I know. If the person is not facing you, and you come in a room or something and you think they heard you or they're ignoring you or something, you might want to make sure you come around and maybe a light touch on the shoulder or just something where you can get in front of them. Because when I don't have my hearing aids on, I don't hear anything behind me. So I don't hear if you came in a room. I don't know if you're already talking to me. And it can seem like I'm having a bad day because I'm not talking to you. And then sometimes, that can escalate. But just be a little patient with us. So make sure that we're facing you when you're speaking with us. That's all.
Thank you, Judith. We have a question from the audience about getting hearing aids replaced and whether that can be a long and expensive process or not. And I'm guessing that that's a shared experience for many of you, that trying to get hearing aids and equipment replaced is expensive and takes a long time. It can, depending on your situation, right? Jeannie?
I mean, it most usually requires another trip back to the hearing instrument specialist or the audiologist themselves. I think the most maybe that I've waited for a hearing aid to come back is maybe 2 to 3 weeks. But I just can't go, oh, I need it replaced. They want you to come in and especially if your hearing aids are on the old end, to make sure it's important to continue to have your hearing evaluated to see if there's been any changes. Because my loss has been progressive. My hearing loss has changed through the years. So, it's not one and you're done. You've got to keep having that evaluated and making sure your hearing aids are programmed properly and that everything's functioning.
And it's a process too for the people around you to learn how to adapt. My dad just got his first set of hearing aids, and my brother-in-law got hearing aids. And at Christmas, his wife forgot her phone, and somehow he had all his calls going to his Bluetooth into his ear, directly to his hearing aid. So he was getting all kinds of messages he didn't need to hear because it was going to the Bluetooth and through the hearing aid versus somewhere else. So sometimes there's humorous adaptations as you get used to the hearing aids as well. You've started, a few of you, talking about the adaptations for the environment that help. So I'm going to invite Emily. Could you talk a little bit about how a room or a setup can either help or hurt effective communication? What are some things that providers need to be aware of when they're setting up a room or setting up a meeting?
Looking at my notes here, So, these are the little things that we don't think about for those with a hearing loss. It's the lighting. You don't want it too bright, too dim. Too bright, you can probably deal with it, but if it's too dim, you can't see that because we're such visual people. We read body language. So I know a lot of counselors like to keep the room dim, keep it soft, keep it, relaxing, which I totally understand the vibe. But sometimes we just can't handle that because we need to be able to see your faces. So that's very important to keep in mind. And then never ever put the window behind you or the person that's going to speak. You can tell Michelle has a window behind her, but she has a black curtain. So that's obviously because it blind the person that's trying to understand the person that's speaking. So that's one of my biggest pet peeves. I'm like, you'll catch me scooting around like I won't just tell you, but I'll say, I can't see, I can't see, can't see. Oh, there we are. Then we're good. So, and then too large of a space, like Jeannie said, she likes to be up close, um, so that she can able to hear and to understand everything that's being said. That is just a conversation that you need to have with your patients, just to find that happy medium, just kind of just wherever they will be the most comfortable doing. I know that can be a out of the personal space, but that's the last thing we're thinking about. We're just trying to hear and understand everything that's being said. We're not thinking about being all up in your personal space. So, the one thing that to avoid when you're trying to decide whether you're having an individual one-on-one session or even a group session is what depending on the layout of your facility, is the room far away from the lobby? Is the room far away from where people like to stand and chit chat? Because you'd be surprised, hearing aids picks up everything. So if we hear any background noise or just little chattering in the hallway, like for myself, my brain is fighting to listen to this or listen to you. And so if we can eliminate that, then it will be a less exhaustion. Um, some people talk loud, and that could because they can't hear themselves, or like me, when I'm emotional, I get loud. So, um, something that where that they may feel a little more comfortable of sharing and not have somebody that's eavesdropping. I mean, I don't know if hearing people are like that too, but I know myself, I get loud and I'm like, I'm sorry, I don't want to interrupt anybody. So those are just little key things that you do. Now with the group setting, it it gets tricky because I don't know what a group setting typically is. Is it 4 people or is it 10 people? If it's 4 people, some people may do okay with accommodation. 10 people can be a little overwhelming. So you'll need to make sure that the room's just not too large or too much airspace where the sound is traveling. And then something to always think about is accents. Those are one of the biggest challenges, especially for me, is I can communicate one-on-one very well, but if your English is second language, but you've been here a long time, I might do okay. But if you have a group therapy that has a lot of international residents or just various accents, that could create a barrier to because not only are we trying to read their lips, we're trying to process what they're trying to say and trying to match it in English. So it's doubling the work. So those are one of the biggest challenges that you may want to keep in mind.
Thanks, Emily. I'm going to ask Anthony now, because of his experience with using interpreters, what are some suggestions for setting up a room for individual therapy, family therapy, or group therapy to make it more accessible?
Well, from my own experiences that I've had with family, group, or one-on-one therapies, um, you, you know, you have to kind of get a sense of the room, get a feel for the room, what matches for me well. If I'm with my family in a group, I like to set up myself in a situation where, as an example, I'll sit in the middle of this group so that I can see the therapist in front of me, but the therapist may have the interpreter next to them, and then other family members be dispersed throughout the room, and I see everyone in that semicircle. But typically, when I go into family therapy, there's too many windows, there's too many curtains, there's too many things to distract me. So I will ask that therapist, could you move to another room that has, a solid wall, nothing distracting visually? And it's so much better for me. If I'm doing one-on-one, I can set that up with the therapist, just sit down with them and have the interpreter next to the therapist. And I therefore can see clearly I have very few distractions. Now, lighting, it doesn't typically bother me, but for other individuals it could. And so they may ask you to dim them or they may ask you to brighten them. So it may depend on what their needs are.
Does anyone else want to comment on environmental considerations? Jeannie?
Just very quickly, if I was sitting on the provider's end of this right now, I'd be excited listening to these things because these are things that don't cost anything. I mean, making sure you're in a room that has good lighting, making sure you have soft surfaces like carpeting on the floor, rugs on the floor, or all of those things are so easily available and can really solve a lot of hearing problems, listening problems that we have. So I think that's one thing. If I was the provider right now, I'd be going, oh yeah, I can do those things. This, it's not going to be all that easy, but those things you can control to a degree.
That's a great point. It also makes me think about another free accommodation that we can all make that makes a huge difference is our attitude, just our willingness to ask the questions and to do what's needed to give a person the accommodations that they need. Judith?
Yes, attitude matters, and also giving them time. Like it may take like 45 minutes is not, if that's the regular time for a client without hearing aids or hearing loss, it takes longer than that. It can take us longer to kind of get our thought out. And so it can be pretty frustrating because I don't know in billing, I know in our billing system, they don't allow generally, they allow a peer support and I can see someone for longer than an hour. But oftentimes there are billing restrictions against that. So just know that you might not get a lot covered and just be, or as much as you'd hoped, and just be patient with people.
That is such a good point, because even in meetings, I know I overpack agendas, and I'm learning with lots of coaching and trial and error to put fewer things on the agenda to make sure that we have longer to cover things and allowing that processing time. Some of our Medicaid managed care organizations do allow for extended session codes and for interactive complexity codes. So if you're in a behavioral health program, you might look into that as an option for those longer sessions. We also recommend a pre-session. So if you are using an interpreter, meet with them ahead of time. Make sure that if you have an assessment, if you have any content that you're covering, you give a copy of that ahead of time and discuss any vocabulary that might be used and see if they have suggestions for how to make something go smoother. All right, the communication access plan also asks, what do you need the office or facility to provide? And goes into detail about different equipment. Our next two workshops in the series will go more in depth about what those mean, and I will send people the opportunity to register for those as a follow-up to this session. For today, though, I have questions for you all about hearing assistive technology, just surface level. Is there any technology that any of you find useful for staff in an individual or a group setting? And I'm thinking of one that we don't use enough that's fairly simple. It's just an amplification, like a microphone. If you're in a big group meeting, having a microphone and then saying, oh, I don't need to use the microphone is a no-no. Instead, making sure people do use a microphone. That's one thing you can do in a meeting to make it better. Any other suggestions for hearing assistive technology? Have any of you used FM systems before?
Yes.
Okay.
I'm kind of thinking outside the box here, Michelle. Are you thinking like one-on-one or group therapy?
Either.
Because I'm thinking in group therapy, personally, I think an interpreter or a captioner would be the better route. And that's just me because some people in your group therapy might be too shy. The thought of having to hold a microphone or a pocket talker, like your goal is to get people to talk, not to retreat. So,
Right.
a lot of times if you give them a microphone, whether it's Bluetooth to the hearing aid, they may retreat. But if you have a sign language interpreter or a captioner, then they don't have to do nothing. They can just be themselves. So, but that's not an answer for everybody. That's just me just thinking outside. I personally have not experienced group therapy, so I honestly don't know what accommodations I will need. I'm the type of person that let me go one time, let me check it out, fill it out, and then address it from there. Because I'm very mindful of what how much these services cost. So that's because that's just my line of work. And so I know that, but I also know that if I do need accommodation, that I'm not afraid to ask. Like, okay, I really am struggling. I need this. But I'm also one of those, no, I'm doing fine. I don't need that, because it's just that's just me because that's what I see every day. So, but don't assume that will be the case with everybody. I think I'm just a special case. So, but that's just something to think about. Yes, these accommodations do cost money, and that's where the budget comes into the place of when you're writing your budget for your facility is making sure you have accommodation covered for your patients. But in a group setting, it might be just something to really think about because your goal is to have your session effective, not make it awkward. So that's just my thoughts.
Thank you for that. We are running out of time. So I'm going to get us to kind of our wrap up questions, Judith, unless you have a quick thing to add right now.
Pocket talkers are helpful. And also just simply going over the guidelines for the communication at the beginning, reminding people to not speak more than one at a time, and also no sidebar conversations. helps a lot too. That's all.
I'm so glad you brought that up because one thing we've implemented in our department this year are communication agreements. So usually at the beginning of a meeting, we have communication agreements that Anthony reviews, and then we see if anybody needs to add anything. We have one set for virtual settings and one set for in person. So that can be another thing you implement in a group setting. They usually fall apart and then you have to remember again to do it. But getting in the habit of expecting people to communicate well and practicing that can be really, really important. I think, Emily, you also spoke to the importance of trust and the importance of time. You know, it may be that you need something, but you don't ask until the second or third or fourth session because you're not sure if you can trust this person, or things might change. I've also heard some of you on the panel say that it's a lot easier to advocate for other people than it is to advocate for yourselves. So you may be like, fine, I'm going to fight for this other individual who's not getting what they need, but I'll just take whatever comes, you know, so there can be a lot going on at any given time. As we wrap up, this has been a great conversation and it's gone really fast. I would love for you to each share one thing that you think providers can do differently or better in order to engage with you, a takeaway to have about respectful dialogue around communication access. Crickets. Nobody wants to. Oh, Emily, go for it.
The one takeaway that I want providers to, what was the question? I want to make sure I've tied it in.
What is one takeaway that you'd like the audience to have about respectful dialogue around communication access?
So, for me, I'm pretty open about it because I grew up with it. It's just part of who I am. So, but your first appointment will always be awkward. Your first time using accommodation will always be awkward, and that's okay. So, when you're having these dialogues, just be honest with them and let them know that this is, your first time. And I'm very excited that we can have this here. You just kind of let them know that they can trust you. And it's to tie it back to the communication access plan. The goal here is to remember what their communication for that patient. So if you can go in there and have everything ready before they get in the room, they're like, yes, they got it. So it does take a little extra time, but you can, I think it's very important that if you listen to them and have that conversation and to really take notes on what they prefer. Do they like to prefer the light to be dim? Do they like to prefer it to be bright? Would they, what are just those little things that they like? And just to jot it down, and then when you have your next appointment, you have the room set up. If you have an interpreter, you already have the interpreter, just to show that you're making an effort to provide accommodation. Because what people don't understand is when deaf and hard of hearing patients are getting services, the first thing on their mind is, will I have an accommodation? Will I have an interpreter? Will I have captioning? Because they can't deal with nothing else until that's in place. Mm-hmm. So if we can get that resolved and ready to go when they walk into the room, you're going to have a good session. That's just key.
Excellent advice. I'm going to invite Tessa to go next because we haven't heard as much from her today. There you go.
I would want to be believed that I'm hard of hearing. I know I speak somewhat well. I still have a hard time speaking certain words, but it's like my experience at the jury duty here in Winchester was just an awful experience because I went in there There was no interpreter there when I requested one because it's a big group, huge, and I can't hear everything that's going on in the courtroom because it's echoing. So I didn't have one there, and I asked the security guard, "Where's the interpreter?" I made the mistake by speaking. I should have not spoke.
Mm.
So he didn't believe me. So he's like, "You're speaking fine to me. You're fine. I mean, you can hear. You can fine." So he didn't understand. He didn't believe me, and that's very important to believe that if you're deaf or hard of hearing, whatever, believe them. We're not pretending. We're not pretending. We don't have selective hearing, like most hearing people think. But anyways, the judge told me to bring proof that I was hard of hearing to get an interpreter. To get one there, it was awful. I went into my car afterwards and just cried. And because I felt belittled, I felt this is what happens to deaf people like all the time, and this is just not right. And I don't know if they just didn't believe me, they would think I was trying to get out of jury duty, or I don't know. No, I was really interested in it, but after all that happened, I was not interested in it anymore. But I didn't get in. I was hoping to get in, but anyways, but yeah, that was just believe us.
Thank you for being willing to share that, because that is traumatic when you're not believed over and over again, and when you have to fight just to be accepted for who you are and what you say you need. So there's a level of interpreter insecurity, there's levels of discrimination and oppression and judgment that a lot of folks are coming into treatment with. And if we as providers do not do what is right and what is needed, we are never going to build trust, and we're going to re-traumatize the folks that we're serving. And often we can misdiagnose what's happening as well. People may not be presenting in the way that we're used to. And instead of getting education or getting support, providers may diagnose because it's faster and treat what they think is happening versus getting that full picture. So as a program, we are trying really hard to educate our providers to center the experiences of folks who have hearing loss or who identify as deaf, and to build capacity across our system of care. Our next session is going to be on May 9th, and we're going to talk about captioning, about video phones, and the audiologist perspective of different hearing assistive technology. And then May 15th, we have a bonus session where we have folks from the SHED Association, the SHED something, who are going to be talking about hearing assistive technology and national resources. And then we'll wrap up the series in June, talking about the experiences 7 counties and New Vista had implementing the communication access plan in their agencies. We are almost out of time, but I would love, in just a few words, Anthony, Jeannie, Judith, do you have any takeaways that you would like to share with the group? Jeannie?
I would just encourage the providers to invest the time to collect the information that you need from us up front. That may slow you down some, but later on you'll be able to move forward in a better fashion. To just take time.
Thank you all so much for your openness, for sharing your experiences, and for the good work you do to try to improve behavioral health care and all deaf and hard of hearing services across the state. Thank you to Laura, our captioner, to Linda and Shannon, our interpreters. And I hope you all will join us for the rest of the series. I will be sending out a follow-up email with resources and for the signups for the follow-up sessions. Thank you all and have a great day.